So with my disclosures, although I'm an interventional cardiologist and there's the incidence of coronary artery disease is falling, and maybe I should start putting my shop out on the sidewalk and we'll cath for a hot meal. I do give talks, but I'm fairly even in that I give talks for all companies, and that either makes me completely corrupted or balanced in my corruption. Next slide, please. So these companies, as you will see, make thank you, antiplatelet agents, which I'll be talking about, but they all make them. Next slide, please. So hopefully, without boring you, I'm just going to touch very briefly on the history of the evolution of antiplatelet therapy, and we'll talk about the use of aspirin and the evidence base for it. We'll talk about the non-aspirin antiplatelet agents and the evidence base for their use, including the newer ones, Prasugrel and Ticagrelor. I'm going to touch on the optimal antiplatelet therapy duration. I'm just going to touch on that because no one at present really knows. It's a balance between anti-ischemic benefit and the risk of bleeding. And I'm going to briefly discuss some special circumstances if a patient requires concomitant surgery or a patient who's also on anticoagulation. So with regard to acute coronary syndromes, this is my bread and butter. This is what I deal with on a daily basis, where you have an atherosclerotic plaque rupture, and if you have platelet plug forming on the plaque such that you have complete vessel occlusion, you have ST segment elevation, ACS. These tend to occur between the hours of midnight and 6 a.m. So between them and my children, I don't get much sleep. And in the older days, fibrinolysis was used with either TNK or streptokinase or whatever, but more recently we now have a fairly comprehensive primary angioplasty program across the whole of the Greater Toronto area. And depending geographically where you have your symptoms or where you live, you will be taken to a certain primary angioplasty centre to achieve fairly rapid reperfusion. The commoner burden we see is those with non-ST segment elevation acute coronary syndromes, where they have a plaque rupture, there is a platelet plug formed in it, but there is still some flow through, so you tend to get some myonecrosis, but not a huge amount. And the mainstay of treatment for these is antiplatelet therapy, anticoagulation, and then undergoing diagnostic angiography with a view to revascularization. Throughout all of these, aspirin and the other adjunctive antiplatelet agents, which in the past was Clopidogrel, and I'll show you some newer ones, are integral to the treatment of all of these, such that we're trying to reduce the rates of reinfarction or death or recurrent ACS in both paths. So the antiplatelet agents available, orally we have aspirin, obviously, old school. We've had Clopidogrel now for 10 years, and in the past 15 months or so, Prasugrel has been available, and more recently I will touch on Ticagrelor, which is approved but is not really available yet. There are intravenous and parenteral preparations going, which I won't really bore you with tonight. Next slide. Again. So the use of aspirin in non-ST elevation MIs and unstable angina, this is a bit like going through the First World War. It's ancient history. But I thought just to give you an idea of the rates of things, we would touch on this. One of the issues is that when I was training, people come in with a non-Q wave myocardial infarction or unstable angina, and the definition has now changed markedly. Now, the reason we can't go back and perform these studies comparing aspirin versus placebo is it's unethical. So we're stuck with the previous definition, and the evidence does date back to the 1980s. And the reason you can tell it's the 1980s is that you cannot get an electronic version of this. You have to print it off, scan it, and then import it into your presentation. This was actually a Canadian study, and Canada has been very good and at the forefront of a lot of these interventional and acute coronary syndrome trials. With 550 patients with unstable angina, it was a trial comparing aspirin and sulfentrazone, both or neither. A fairly high dose of aspirin, 325 QID, and the duration of aspirin, if you go down one, I was actually going to question everyone on this. That's okay. 2 years, so fairly high dose of aspirin, 4 times a day for 2 years. And next slide, please. And looking at the event rates within this, the patients who got aspirin, whether they received sulfentrazone or no sulfentrazone, the event rate was either 9 or 8%. No aspirin was double that. So this was 325, 4 times a day for 2 years. And the absolute risk reduction was 50%, highly statistically significant, but as you would perhaps expect, 29% more common GI side effects. Now this was published in the New England Journal, and the GI side effects were dyspepsia or ulcer. And nowadays they would need a much harder endpoint than that. But this is going back to the 80s when things were allowed. This was an American study in the Veterans Administration, which is why it's only in men. Again, very similar, unstable angina. Aspirin 325 once a day, and next slide, which this time was continued for only 3 months. But again, a previous slide. A fairly impressive reduction. So the rate of death of myocardial infarction was halved, as was non-fatal reinfarction. Again, highly statistically significant, with a trend towards reduction in death in what is meant to be a fairly low-risk group. And they noticed there was no difference in the GI side effects of bleeding, but again, it was a smaller dose for a shorter period of time. Move on. So then, just as I was going into medical school, ACS 2 came out, which was one of the largest studies looking at aspirin in ST elevation MI patients. So this was, and the other thing about this is that nowadays you've got all these acronyms of studies. At least ACS was the International Study of Infarct Survival. So it does what it says in the tin. It was basically seeing how many patients survived. And it was comparing streptokinase and aspirin versus both and neither in just over 17,000 patients. And again, the aspirin was, next slide, was only for 1 month. So a very short duration. And the endpoint in this study was death at 1 month. So it's a fairly hard endpoint. You're either dead or you're alive. Go for it. And as you can see, over here is aspirin versus placebo, and at 1 month, the absolute mortality rate following out an MI in the 80s was 12%. Untreated was 12%, so 1 in 8 patients were dying. Reduced down to 9.4%, an absolute reduction of just over 2%, which nowadays would be almost unheard of in one of these trials. This was comparing streptokinase versus placebo, which also reduced it. And the combination of streptokinase and aspirin, which nowadays is very standard, was revolutionary at the time. And it reduced the mortality by 1/4, which was huge in those days. And nowadays, you would never get such a reduction, and that's why we now have to go to composite endpoints, where they've got a lot of other endpoints in to reach statistical significance. So that's the acute, and I know this talk is on acute coronary syndromes, but the antithrombotic trialists looked at aspirin following this when patients who are on long-term aspirin. And the reason that we use the dose of aspirin that we do, we found that basically anything less than 75 milligrams per day crossed the line of unity, so we would say it was non-statistically beneficial, whereas 75 and above, all of these are to the left of the line of unity. The problem we have is that above 150 milligrams, the incidence of GI side effects is much higher. So for long-term management and antiplatelet therapy, we would recommend between 75 and 150 milligrams, which in North America equates to 81 milligrams once a day. So for many years we had aspirin as sole antiplatelet therapy, but there's an awareness that aspirin only acts on the cyclooxygenase pathway. So there was interest in inhibiting other modes of platelet activation, including the ADP receptor. There's also been some recent interest in some phosphodiesterase inhibitors, which I won't talk about. And again, almost ancient history, the initial ADP receptor blocker was ticlopidine, which was very effective, and we used it initially, but there's a lot of toxic side effects with it. You had to monitor white count and things like that. So that sort of fell by the wayside and led to the development of newer, more safer ones. So the 3 compounds I'll talk about tonight are Clopidogrel, Prasugrel, and Ticagrelor. We'll start off with Clopidogrel, which is the one that we're probably all familiar with. Now, when we take Clopidogrel, about 85% of it is inactivated following hydrolysis by an esterase in the gut. Thereafter, you still have the prodrug, which is not active, and it takes 2 enzyme-dependent steps to activate the Clopidogrel, which would explain a lot of variability in its action and the delay in the onset of action, of its action. Go forward one. Clopidogrel was assessed in the CURE study, which was clopidogrel in unstable angina to prevent recurrent events. So this was in about 11,000 patients with an ACS without ST elevation, so either unstable angina or a non-ST elevation MI. Clopidogrel was given up front and continued for an average of 9 months. And again, going back to what I was saying about the composite endpoints, the primary endpoint was a composite of cardiovascular death, recurrent myocardial infarction or stroke. And this, so before I was telling you the 30-day mortality following a STEMI was 11%. Nowadays you've got a 1 year combined of all these of 11% in the placebo group, but it came down to 9.3% in the Plavix group. So this was a 20% relative risk reduction, but absolute numbers of only 2% of a composite endpoint. But again, highly statistically significant. And this meant that nowadays we're giving out Plavix as if it was candy. And I bet a lot of your patients are coming home from the hospital on this. One thing we did notice is that when your patients do come into the emergency department with an ACS, if we give them the Plavix up front, that the curves between Plavix and placebo separated very early on, and we became aware that upfront platelet inhibition was beneficial in preventing recurrent events. That was an unstable angina, non-ST elevation MIs. Clopidogrel was evaluated in 2 STEMI studies. Clarity TIMI 28 was a North American study with the main idea was to move on to an interventional therapy. And the COMMIT study was a massive study performed in China of about 46,000 patients looking at both clopidogrel and metoprolol. Because that was a bigger study, I'll concentrate on that. So it was almost 46,000 patients. The co-primary endpoints were going to be either death and then a composite of death, reinfarction or stroke. And the safety endpoints were going to be looking at bleeding or hemorrhagic stroke. The forward one. And again, the only followed the patients up to 28 days, and the CURE study was out to 9 months. But with that, there was a 7% relative risk reduction, which was statistically significant, but only a 0.6% risk reduction, absolute reduction in the composite of death, MI or stroke. And this just goes to show you that as our treatment has improved across the board, the event rate is falling and falling and falling and falling, that you can no longer get statistical significance without compositing it with other outcomes.
This is aspirin plus clopidogrel, right?
Yes, in patients who have been thrombolyzed. So they've been given TNK. And in the Greater Toronto area, very few patients get thrombolyzed now. The previous smaller study, the Clarity study, did show a benefit in the patients who underwent intervention. But again, even that, thrombolysis and then intervention, very few patients get thrombolyzed now. And so again, looking at the composite of death, MI or stroke, relative risk reduction of 9%, but absolute numbers of less than 1%, but again, statistically significant, only because there was 46,000 patients in it. The downside of clopidogrel, and I'm sure quite a lot of you have seen this, there are various ones. Some of them are the lack of efficacy. Some patients are intolerant or are resistant to it, which is a big problem for us. But one of the commonest things that we see is this rash that we get. It's a really itchy macular rash that can make the patient's life misery. And in worst case scenarios, they can get desquamation of the palms and soles of their feet. It can occur in up to 16% and causes cessation in less than 2%. And actually, I didn't put the reference up here, but we, from St. Mike's, we recently just published a paper in the Journal of American College of Cardiology showing that if you get these patients, you can give them high-dose steroids and antihistamines and successfully treat this. But it's a bit of a hassle having to do that, and to have any alternatives that may not cause this would be beneficial. So going through the ones I'll talk about today, so clopidogrel is an irreversible inhibitor of the P2Y12. We give a 600 milligram loading dose, and it usually works within 2 hours. Maximal inhibition at about 6 hours, and one of the things for family doctors to be aware of is that once you stop it, it's going to be swilling about for 5 days, so the patients will still be prone to bleeding. Prasugrel is also an irreversible inhibitor, and as you will see in a minute, it doesn't have to get through this hydrolysis phase. It's got a much faster activation. It will start working within 15 minutes and is maximized within an hour. But again, it takes about 5 days to wear off. Ticagrelor is reversible, it's shorter acting, and you can get the platelet inhibition will start within 30 minutes and maximal inhibition between 1 and 3 hours. And although it says here it takes approximately 2 days to wear off, the recent product Monograph is recommending 5 days like the others. So although we're being told that it's got a shorter offset, it does appear to be fairly long. So talking about Prasugrel, it's ingested as a prodrug and then goes through one enzyme-dependent activation to become the antiplatelet, the active antiplatelet agent. Go forward. And to show that it is more effective, and I'm not going to show you a lot of lab tests, otherwise for sure you will fall asleep. But if you give someone a loading dose of Clopidogrel and then maintain them in 75 milligrams per day, the percentage of platelet inhibition is pretty good, but it's still not great. We still get a lot of recurrent events. A loading dose of Prasugrel, 60 milligrams with 10 milligrams of loading dose, will bring the platelets down until they're completely inhibited. Go forward. And again, patients that we have done elective angioplasty on, comparing Clopidogrel versus Prasugrel, we find that the percentage of subjects with good inhibition of platelet function is much, I beg your pardon, with still residual platelet activity is much lower in the Prasugrel group, basically showing that Prasugrel is a much faster and more potent inhibitor of platelet function. Prasugrel was evaluated in the Triton-TIMI 38 study, which was 13,500 patients with fairly high-risk acute coronary syndromes, encompassing some patients with STEMI. And because it was a very recent study and we know the benefit of intervention now, the intention was for these patients to go on to angiography and angioplasty. And they were randomized to aspirin and then either Plavix or Prasugrel, which was continued for between 6 and 15 months. And the primary endpoint was a composite of cardiovascular death, non-fatal MI or CVA. And the safety endpoint was going to be major bleeding. Go forward. And again, there was statistically significant reductions in the composite of cardiovascular death, MI or stroke. So the absolute reduction was 2.2%, but a hazard ratio of 0.81 and was highly statistically significant. No significant reduction in cardiovascular death, but reduction in the rate of reinfarction, no change in stroke, and no real change in death from any cause. TVR is an interventional cardiology phrase that relates to target vessel revascularization. It means we've done something wrong. We do the angioplasty and we think everything's fine, and then we get called in the middle of the night because there's a problem. And it usually means that the stent that we put in has thrombosed, and there was a statistically significant reduction, 34% reduction in the instance of that with the Prasugrel, borne out in a reduction in the stent thrombosis rate. That's where the stent clots off and is a very bad prognostic feature. Go forward. Again. The only fly in the ointment with it is, as a very potent antiplatelet agent, it does cause slight excess in bleeding, which was statistically significant. So there are various definitions. TIMI from the group in Boston, major bleeding, there was a 32% excess in that. In terms of life-threatening bleeds, there was a slight preponderance of that. And across the board, thank you, there were slight excesses in bleeding within this, as you would expect with such a potent antiplatelet agent. And again, I'll leave that, just go forward. Now, bearing in mind that 30% of our patients are diabetics, the absolute benefit in diabetic patients or patients with diabetes is much more pronounced. Excuse me. So these are the patients without diabetes. You should note that they have a lower event rate anyway, just over 10%, reduced to 9.2% with the Prasugrel. That's a primary composite endpoint, and the reinfarction rate was 8.7 to 7.2. But in the patients with diabetes, higher event rate, 17%, and the composite endpoint out to 450 days, but reduced by almost 5% absolute, or 33% relative. And in the reinfarction rate, again, higher compared to the non-diabetics, but with a large amount of reduction with Prasugrel. And with this, if you look at the, hang on, yeah, so this is bleeding in patients with diabetes, and there was no significant difference in the rate of bleeding in those with diabetes. So Prasugrel appears to be a very effective drug to give to patients with an ACS, particularly those with diabetes, where there's no real concern with bleeding. In the STEMI subgroup, again, statistically significant benefits. So a lot of your, and now in the Greater Toronto area, a lot of the hospitals, if someone comes in with a STEMI, they're using Prasugrel beneficially or preferentially in most patients. So you'll find that more and more of your patients are going on this because of the benefits in terms of death, reinfarction, and non-fatal stroke. And in the STEMI group, there was no significant difference in rates of bleeding. Go forward. The only caveat with Prasugrel is that we did a the sponsoring group did a post hoc analysis of all the patients, and we found that in patients who had a previous stroke or a TIA, it was actually dangerous to give Prasugrel. Clopidogrel was statistically better than this, and it was harmful to give the Prasugrel. And as a contraindication, now if you have a previous stroke or TIA, that we would not recommend that you give this. There was a neutral effect in elderly or patients who were older than 75, and again we're seeing more and more patients who are older than 75. So the benefit in that was not evident. The younger ones, that for sure there was a benefit, but this crossed the line of unity. And also in very, very light patients who are less than 60 kilograms, again crossed the line of unity. There weren't very many patients with that, but in patients who are over 60 kilograms there was it. So for sure, if you've had a TIA or CVA, it's a no-no to give this. The other ones is at the operator discretion, and you would take other features into account.
Is it risk of bleeding post-TIA or risk of...
Yes. So all the bleeding parameters were commoner. So GI bleeding, intracerebral, whatever, were much commoner in patients who had a previous stroke. So I'd say that the take-home message with regard to Prasugrel is it's very effective. It's got a rapid onset of action. It's got a very predictable action in that it only goes through one step to be activated. And in STEMI patients, in particular the patients with diabetes, it appears to have additional benefits. There was excess bleeding with it, and we should use it with caution in certain groups. And it's contraindicated with a previous stroke, and perhaps used with caution in those with a low body weight or in the elderly, and perhaps lower risk ACS patients. This would be decided probably by the interventional cardiologist undertaking the PCI.
Hypertension a factor as well?
No, no. So the subgroup analysis showed nothing with that. So the final one we'll talk about briefly is Ticagrelor. Again, this has just been approved by Health Canada. Go forward. Again. So this is actually, it's ingested as the active drug. It doesn't have to go through any activation steps. It's reversible. It's a direct inhibitor of the ADP receptor, and has a more rapid onset and less variability of action than Clopidogrel, similar to Prasugrel in that fashion. And this was evaluated in just over 18,000 patients with an acute coronary syndrome who were randomized to receive either Plavix or the Ticagrelor, and it was continued for a year. Come forward. And again, looking at excuse me, the composite endpoint, which was vascular death, MI, or stroke. At 1 year, the rate in Clopidogrel was just almost 12%. It was reduced to just less than 10, which was a 16% reduction and was statistically significant. All-cause mortality, reinfarction, or stroke was also reduced, as was this fairly large, long-winded composite endpoint, statistically significant. Go forward. The interesting thing about this was that there was a significant reduction in vascular death on its own, and this is one of the first studies that's shown a reduction in mortality, which set a lot of the cyber babble talking about it. And there's a lot of blogs about this and basically saying it was the best thing since sliced bread. Go forward. And that this was done without any excess in bleeding. The hazard ratio for bleeding was 1.04. The only issue with this is that we know, I'll show you some data later on, that bleeding following an ACS is bad. And usually you see that the reason that Clopidogrel or these drugs, for them not to cause any excess bleeding, to say that they're fantastic antiplatelets, and there was something else going on here, and I'm not sure if this is statistical play of chance or what, but if you do subgroup analysis, you will see that patients who, if you take out cabbage-related bleeding, there is a significant excess in bleeding with this if you look at subgroup analysis within it. So although overall there was no excess in bleeding, if you look at the product monograph, they're actually warning that there is an excess of bleeding with it. So I would take a lot of the data with caution that they present, because there does appear to be some excess bleeding. Go forward. Again, the results that we saw, if you looked at the patients who underwent angioplasty, which was the vast majority, significant benefit with the drug. Go forward. And also in the STEMI patients, again, as an interventional cardiologist, we're treating these a lot. Again, significant reduction in all-cause mortality, which again is difficult to realize, because you would then expect to see, usually mortality is due to bleeding, or there's a signal that there's excess bleeding, you would expect excess mortality with the inferior compound, and there isn't any excess bleeding. So it's just one of the things that it just needs further analysis, I think. Go forward. Now, I'm going to very briefly, I'm basically saying that potent antiplatelet agents are better, and we have a half-decent one in the form of Clopidogrel. So the Gravitas study was basically, why don't we double up the Clopidogrel and follow patients out to see if there's a reduction in events afterwards. Go forward. It was a 2x2 factorial design where patients were randomized to high-dose aspirin or low-dose aspirin versus high-dose Plavix or standard Plavix, okay? And essentially it was a negative study. The instance of the composite endpoint, CV death, myocardial infarction or thrombosis in the stent, was the exact same after a year. And remember, it was only a week of high-dose Clopidogrel and a month of high-dose aspirin. But out to 210 days or 9 months, there was no significant difference in the composite endpoint. The only thing within it is that the risk of bleeding appeared to be related, non-significantly, but appeared to be related to the dose of Clopidogrel. So high-dose Clopidogrel, there was a non-significant numerical excess in bleeding in the patients who received high-dose Clopidogrel. Further subgroup analysis has shown that in a small cohort of patients who underwent angioplasty, that there was a reduction in stent thrombosis. So some of your patients who are admitted acutely may come home on high-dose aspirin and high-dose Plavix, and it usually stipulates that one of them's for a week and the other one's for a month, and that should be stated with by the interventional cardiologist.
What is high dose of Plavix?
150 once a day, so double dose Plavix, 150 once a day usually, and the aspirin is 325 for a month. On an aside note, the American Heart Association guidelines for angioplasty are that patients go on 325 milligrams of aspirin for a month, for 3 months following bare metal stent and 6 months following drug-eluting stent. And very few of us use that because the evidence base behind it is lacking. It was just one of the trials used that, and it's been adopted. So we tend not to put patients on the higher dose because of the higher instance of GI side effects.
What was it that one was a week and one was a month?
Yeah, the high dose Plavix was for 1 week. It was 150 milligrams OD for a week, and the aspirin was 325 for 1 month.
In that study?
Yes.
And what was the difference?
So there was no difference in the composite endpoint. So there was 4 groups. There was standard dose of both, high dose of both, high dose of one and standard of the other, and standard dose of one and high dose of the other. And looking at it all, the composite amongst them all was the exact same, either high dose Plavix or standard dose, or high dose aspirin or standard dose. The endpoint was very similar.
So it doesn't matter?
Pretty much. But again, looking at subgroups of subgroups, the patients who underwent angioplasty and the higher risk presenters, they benefited from high dose only in terms of stent thrombosis rate. And we will often do that. So if I am doing an angioplasty in someone and there's a lot of clot there, then we may put them on high dose of both of them, and we will usually stipulate that in the discharge summary going back to the family doc.
Oh, if they've got a stent?
No, if they've got a stent, yes, but a lot of patients get stent and we use regular dose, but if they had some clot evident, then we would put them on high dose, because there was a reduction in the instance of stent thrombosis, which was small but statistically significant. because the previous slide showed that the instance of GI bleeding, there was a trend towards increased bleeding with higher dose. So, and we know that from the antithrombotic trialists that 325 of aspirin is associated with a significantly higher rate of GI hemorrhage. It would make our life easier if everyone went in the same dose, but it's not as... So I think that over time, what we're finding is the initial trials comparing, when we added in aspirin, there was a 22% reduction in the endpoint. Then with aspirin and Clopidogrel. And then more recently with aspirin and Prasugrel and aspirin and Ticagrelor. And with Prasugrel, there was a 19% reduction in the endpoint from Plavix. Ticagrelor, it was 16%. Unfortunately, there's been small increases in bleeding ever since then. And I think we'll come to there will be an equipoise between the reduction in ischemic endpoints or ischemic events, but with an excess of bleeding, and we have to work out where the happy balance is between that. Before.
Increase of bleeding. Bleeding where? Only GI or
no.
cerebral?
So there's I'm just trying not to put you to sleep by talking about this. There are numerous papers. There are different definitions of bleeding. There are various research groups that have come out with definitions now. They tend not to worry about where the site is, it's how severe it is. So some of them will say if there's a major bleed, is a drop in your hemoglobin of 5 or a drop in the hematocrit of 15% or intracranial hemorrhage. That is a major bleed. Some of them will say if you have to have any surgical intervention to stop the bleeding, so that would be GI if they have to have a scope, or if it was bleeding from your groin after an angioplasty that had to be thrombin injection, and that would be a major bleed. So there are different definitions. Recent studies have shown that 62% of bleeding following angioplasty are nothing to do with our access site, either radial or femoral, it's somewhere else. And the commonest one is GI, GI or GU. You will often have patients on fairly potent antiplatelets and they'll develop hematuria. And that's classed as a bleeding event.
What's the rate of bleeding?
The rate of bleeding, it's lower now than it was, and it depends on the patient group, but usually at 30 days following an acute coronary syndrome that's treated with dual antiplatelet therapy, you would be looking at approximately, we would usually say 3%, but there was a study recently comparing radial versus femoral access, and it was down about 1% at 30 days. So we're getting better at dealing with these things. It just means it's more difficult to show a difference.
What's the relative risk in the placebo would also have bleeds?
So if we can back up a bit, you need to go back again. So again. Okay, so this is at 1 year. So this is Plato's STEMI patients. So they're getting a lot of antithrombotics, they're getting a lot of antiplatelets, they're going to the cath lab, and the 1 year bleeding rate was 9.3% in Plavix. So, and this was major bleeding. So there would probably be perhaps 50% more than that would be into minor bleeding as well.
What's the background rate? Like you say, the GI bleeds people normally get in that age group of maybe by 7%.
Probably not, it's less than that. So in the original Clopidogrel study, which was, began with a C, Credo, it's going to come to me. It was comparing aspirin versus Clopidogrel to see if they were as potent antiplatelet agents. And the bleeding rate at 1 year was 2.1% versus 1.9. So if you're on one agent, the bleeding rate is 2.1 versus 1.9. Aspirin was 2.1, Clopidogrel was 1.9. Okay.
Once they have a major bleeding, you stabilize them, then it's a relative contraindication to restarting?
No, so I'll show you later on that bleeding is bad news. You can imagine bleeding is bad news, but in a coronary patient it's very bad news. It's a big predictor of mortality for many reasons. And a lot of people think that it's because they start bleeding and they bleed out. It's not that. It's because they bleed, and people don't discuss it with whoever did the stent, and they stop everything, and the stent thromboses and they die of a heart attack. So that's why bleeding is bad. That's perhaps simplifying it. There are other things like when you bleed, you have to get blood transfusion, and blood transfusion is bad for your heart. It makes stent thrombosis more likely. So it depends on the reason for bleeding. If you bleed because you've got a stomach ulcer, you've had a duodenal ulcer with an arterial bleeder at the base of it, and if they inject that with epinephrine and put you on a high dose PPI, then you should be fine to stay on them. But again, it would be in discussion with, I now find that when I do clinic letters or when I do letters, I'm often sending to 5 or 6 different doctors. The copy's going to you guys, the family doctors, it's going to a gastroenterologist, it's going to a cardiac surgeon, just to explain what I want to happen for these patients. Just to make sure, I think the communication is vital for this, so that we're all singing from the same hymn sheet.
So aren't they worse off, because the absolute benefit is 2%? Antiplatelet, right? And the 9% bleeding.
So then you have a net clinical benefit. So a lot of the trials now are doing net clinical benefit, which is the reduction in ischemic events minus the excess in bleeding events. But if you're getting an excess clinical benefit with no bleeding excess, then I think that there's still a benefit.
You were saying the absolute benefit was about 2%.
Yes.
But the cost is 9% bleeding.
But even across that, there is still, but no, there wasn't a 9% excess bleeding. Even patients getting placebo were having 9% bleeding. So because the standard of care now is dual antiplatelet therapy. So we're comparing a newer one versus the standard Plavix, and there was no excess in bleeding with that, but there was an ischemic benefit. Okay.
Give them the Nexium or a PPI?
It's a good point. So there was a study, it's a sign of the economic times. There was a study sponsored by a bunch of venture capitalists in California, that they basically got a license to combine Plavix with Losec. I can't remember the name of it, but it was a great idea. You take one pill and you're sorted. The economic downturn, they pulled the plug on it. And they published the interim results, and it did show a significant reduction in GI side effects and no problem with excess infarcts or anything. So this was an industry that there's been a few lab tests showing that in a test tube, some proton pump inhibitors can inhibit Plavix function due to the fact that they are activated by the same enzymes. And then there was a couple of studies, one in the Canadian Canadian Medical Association journal, and the other one was in an American journal, both of them showing that if you're on a PPI and Plavix, you do worse. But they were observational, and people who are on PPIs tend to be older. They've had previous GI bleeds, they've got more comorbidities. And I think that if you put it through rigorous statistical analysis, it wouldn't really stand up to scrutiny. And this prospective study and numerous other smaller studies have said that there's no benefit. And in fact, one of these, the the Triton study did look at the effect of a Plavix or PPI on events, and there was no, and this was a randomized prospective study. So I think that's put that to bed. Unfortunately, the advice given to pharmacists is lagging behind, and we still get paged saying this guy's on Plavix and such. That's contraindicated, and you've got to say, well, it's not really. Okay. Go for it. So I think that the current state of play, and I'll try and be fast now, is that dual antiplatelet therapy is the mainstay of treatment following acute coronary syndrome, and we prescribe these like candy, as I said, and you guys have got to deal with it. We know that there are limitations to Clopidogrel in terms of hyporesponders and side effects, but there are newer agents available. And I actually did this slide a year ago saying further experience is necessary. And since then, we've got more experience with the Prasugrel, and it's now our default drug for STEMI patients, those who don't have the contraindications we talked about. And I'm not going to make you suicidal by talking about triple antiplatelet therapy, but there was a study recently looking at a phosphodiesterase inhibitor. You'll be pleased to hear it was negative, so that's been put on the back burner just now, okay? So looking at the antiplatelet therapy duration, now, I usually say for blanket that all patients go on it for a year, okay? Now, bare metal stents is a minimum of 4 weeks, but ideally 1 year. And the reason we do this is there was a study called CREDO that compared 1 month versus 1 year of dual antiplatelet therapy. The biggest benefit was in the first month, but thereafter there was still a small but significant benefit in ischemic endpoints in the patients who were on Plavix for the full year. Now, with drug-eluting stents, the minimum duration is 1 year, although you may find that these guidelines will change. And the reason we're concerned about staying on dual antiplatelet therapy is this thing called stent thrombosis. And if you remember back to your pathology days, Rudolf Virchow, who denoted Virchow's triad, which stated that any changes in blood flow, blood composition, or the arterial wall predisposes to thrombosis. If we shove a big chunk of metal in an artery, that's going to predispose to thrombosis. And we like you to be on dual antiplatelet therapy until that stent is healed in. And this study a few years ago in JAMA showed that if you stopped your antiplatelet therapy early, the hazard ratios, you were 161 times more likely to suffer stent thrombosis than if you stayed on them. So we're very aware. This is more of an issue in the United States of America, but a lot of our patients are over 65, and ODB will pay for their Plavix, so usually they are covered. There's the odd patient under 65 where we've got to be thinking about what type of stent we put in that respect. Go forward. This study from 2006, again from the US, was looking at predictors that made it more likely you were going to stop your antiplatelet therapy. So unmarried, high school dropouts who are not working and are anemic were more likely to stop it. And again, this was a very good observational study, but the Canadian experts in the field looked at it, and basically it was less of an issue for us because a lot of this was related to cost. A lot of them may have been unemployed, but we have a fairly good social network here, social assistance network, that will help patients pay for it if they need it. And they found that if you, excuse me, if you continued it, your subsequent event rate, including mortality, was much lower than if you prematurely discontinued it. Go forward. And this is why. So these are scanning electron micrographs of bare metal stents and drug-eluting stents at 28 days. So the BX Velocity was an old bare metal stent, as was the Express. And you can almost see that they've got a nice layer of endothelium. There are very small bits where you can still see the metal poking through. This is a Taxis drug-eluting stent, absolutely no endothelium. And a Cypher drug-eluting stent, no endothelium. Now, these stents have been superseded by much more efficient, much better designed stents, so this is probably less of an issue, but this was a warning sign that, that drug-eluting stents take longer to heal. Go forward. And this is a chap who unfortunately suffered a fatal head injury a few months after he'd had a drug-eluting stent in one artery and a bare metal stent in the other. So this is the radiograph of it, and then they sectioned it out, and what you can see here is that this is the, so the stent strut has been dissolved out of the artery, or has been taken out of the artery, and you can see that there's an inflammatory infiltrate and then a neointima lining of that, so it's not going to thrombose. Whereas these drug-eluting stents have got a very thin layer, and it may not be contiguous, so we're just aware that they take longer to heal. Go forward. And although we know that stopping antiplatelet therapy can be dangerous, with discussion we know that it can be done for short periods. So without boring you too much, this is days after stopping dual antiplatelet therapy. Now Yeah, the red one is where aspirin and Plavix were stopped simultaneously. So the patient thought, what does that cardiologist know? He's useless, I'm stopping them both. And about 5 days after doing that, there is a very steep rise in the incidence of stent thrombosis. If you previously stopped your thienopyridine early and then stopped the aspirin, you have the same signal. However, if you stop the Plavix, as it was then, but continue on your aspirin, then there's a very low rate of problems. And this is one of the things we often get asked about.
So what's the increase in rate of red? I can't see the numbers. How much quicker, how many fold more if you stop both statins?
Oh, so do you know, I actually took the odds ratio out of the hazard ratio out of this. I'm not sure. I will have it on my computer. This is cumulative events, so it will always add up to 100%. But I'm not quite sure what the odds ratio is. Go forward one. I don't think it's. No, it's not. I took it out. So what I would take from this and the previous slide is that if you can stay on the dual antiplatelet therapy for as long as you can, then good. If something has to be stopped, then if you stop the Plavix and continue with the other, and speak to the surgeon about it. Go forward. And so the most important thing about discontinuing your antiplatelet therapy after a drug-eluting stent, number one, is to discuss it with the interventional cardio. And the days of, we are now fielding calls, probably 1 or 2 a day. Our coordinator will take a call saying, there's a family doc, someone needs surgery, can you call them back? And we go through various characteristics with it. And the second most important thing is to discuss with the interventional cardio. So these, I can't emphasize the importance of just discussing it. We don't mind being, this isn't bother, because in the old days when we stopped them willy-nilly, patients were having infarcts. So we prefer to risk stratify who can stop and who can't. So what we do know about discontinuing the antiplatelet therapy if someone needs concomitant surgery is that the risk is highest in the first 3 months after implantation after a drug-eluting stent. So the risk of stent thrombosis is very high. We do know, as I've just shown, that if you continue some form of antiplatelet, either aspirin or a thienopyridine, that the risk is minimized. I've not shown the data in the interest of time, but the newer stents, in particular the polymer that the drug is embedded in, they appear to be much safer with much lower rates of stent thrombosis. And it's really important that we ensure that this small risk of stent thrombosis is worth it. So there are different types of surgery. If someone phones us up and said, this guy's got lung cancer and needs a lobectomy, do it. If he has an infarct, we'll deal with it. But if it's someone who needs their varicose veins or they've got a bit of arthritis and need a hip replacement, then we would say just put up with the pain just now and get the hip done in a year. So there's a sort of, what's going to kill you? Is it going to be your heart that kills you or your cancer? In that case, deal with the cancer and we'll fix the heart. But if it's going to be something that's relatively benign surgery, then I would say delay that if at all possible. And one of the things I'll talk briefly about, which is becoming a commoner problem as our population ages and we're aware that more patients should be suitable for oral anticoagulation. And if you do the CHADS-2 score or the CHADS-VAS score, everyone seems to need anticoagulation. That we often see these patients coming in for an angioplasty who have been on Coumadin or dabigatran beforehand. We will then look at the patient themselves and we'll work out risk factors for bleeding. So we know that older patients are more likely to bleed. Unfortunately, women are more likely to bleed. Smaller people with abnormal renal function, previous history of anemia or GI bleeding are more likely to bleed. And then you have to look at the indication. It's probably more interesting than this.
No, it has nothing to do with it.
And also the indication for the anticoagulation itself, whether it's low atrial fibrillation with a normal heart or a mechanical valve which is at high risk of thrombosis. Things that we look at are the actual coronary anatomy. So if you've got a long lesion that you have to put 2 stents in, the chance of that re-narrowing is higher, so we would prefer to use a drug-eluting stent. And you may get to the stage that you look at how many drug-eluting stents you would have to put in a patient who needs anticoagulation, and you would recommend bypass surgery, because then it can be dealt with and it's done and dusted and they can restart their anticoagulation. And if If we do have to put drug-eluting stents in a person who requires anticoagulation, we would probably ensure gastric protection is achieved with a PPI. And getting back to what I was saying earlier, this is basically showing patients who bleed and their outcome following a non-ST elevation MI. So this is from the time, this is 30 days, so the number of days it takes for a significant difference in mortality. So if you have a severe bleed from anywhere, you've got a 25% chance of dying at 30 days. Moderate, again, was statistically different, but the mild, and even mild with numbers, mild was significant, but if you compare it, there's not a huge difference between mild and none, but there's a bigger difference with moderate, and then if you have a severe bleed, then it's bad news. So this is why cardiologists and interventional cardiologists in particular really do not like patients when they bleed. So this was a very rapid potpourri of where we're at just now. I think there have been recent changes in the field of interventional cardiology and pharmacotherapy. If you think it's bad enough for you guys, you should see there are other antiplatelet agents coming through that we will have to learn about as well. Unfortunately, and particularly for STEMIs, these patients come in the middle of the night, we take a quick look at them, and then we make a decision that you guys are going to have to deal with. So if I see someone and they don't tell me about the previous bleeding ulcer they had, and then I put them on aspirin and Plavix or aspirin and Prasugrel and send them back to you guys, then you may panic or be concerned at my decision in that. But what I would say is that close communication between all the doctors looking after them are going to be essential to ensure that these patients have the best possible outcomes. Thank you. If anyone's got any questions, I'd be happy to.